Hi everyone, my name is Dan and I'm a mental health pharmacist, and today I'm going to be doing a brief video of just the summary of my presentation on dementia and delirium. If you want to watch the full presentation, I have a full presentation of my slides, but this is just a shorter summarized version of the slides if you want a quicker taste of these disease states. Okay, so there's 4 major sections to my presentation. First, I have just a few slides about background to set the scene. Then we'll go over the major sections of the neurocognitive disorder chapter in the DSM, which is delirium, and then neurocognitive disorders, which you can think of as similarly to dementias. And then finally, we'll end with behavioral and psychological symptoms of dementia. So without further ado, let's go into the background. First question is, what is a neurocognitive disorder? So this is the title of the chapter in the DSM-5 that is an umbrella term that includes things such as deliriums and neurocognitive disorders like Alzheimer's disease, dementias, Lewy body dementia, vascular dementia, and so on. All of these share the same characteristic of that the primary deficit is cognitive. Cognitive issues can be seen with many mental illnesses, such as schizophrenia and bipolar, but those aren't the primary concern, whereas with neurocognitive disorders, it is. Here is how the DSM-5 separates the different types of neurocognitive disorders. So first you have delirium, then you have major and mild neurocognitive disorders due to Alzheimer's disease or due to frontotemporal degeneration and so on. So this is how the DSM-5 names them, and it doesn't call it Alzheimer's dementia, for example. So, now that we set the scene with defining these, let's go into delirium. So delirium is a disturbance in attention, and delirium happens over a short period of time, whereas dementias typically develop over a long period of time. So that's one of the biggest differences between the two. Rating scales can be really helpful, and in delirium, the CAM-ICU, if the patient's in an intensive care unit, is a very popular scale. Etiology can be seen here. It's multifactorial, so delirium can be caused by electrolyte abnormalities and glucose abnormalities, but it happens very commonly in hospitalized patients and in ICU patients. There's different types of delirium. There's hyperactive, hypoactive, and mixed. So hyperactive, someone's agitated, moving a lot, maybe aggressive, things like that. So that's a commonly diagnosed delirium. But if someone has hypoactive delirium, they're just confused and quiet and often not diagnosed. So it's really important to check for this because so many patients have it. Polypharmacy is another big contributing factor. So don't put your at-risk patients on a bunch of sedating meds or different types of meds that can contribute to delirium. Next, let's briefly look at the treatment guidelines for delirium. So the SCCM guidelines, Society of Critical Care Medicine, recommends non-pharm interventions, which for delirium are things like if your patient needs hearing aids, give them their hearing aids. If they need glasses, give them their glasses. When it's daytime, have the lights on. When it's nighttime, turn the lights off. Have a calendar in the room, a clock in the room, anything that can reorient the patient to where they are and what's going on. And then the guidelines generally recommend against medications. So no medications have strong evidence that they decrease the duration of delirium. That being said, sometimes antipsychotics are used if the patient's also aggressive or having hallucinations or things like that. But the guidelines don't have much recommendations for medications. Next is the NICE guidelines out of the UK, which say similar things. Non-pharm don't really recommend meds. But let's look at some of the evidence. This is a meta-analysis of 19 trials that showed that antipsychotics didn't really help with delirium. There's potentially some positive evidence, so this showed that after a week, the delirium scores decreased, but there was no placebo group, so maybe they just decreased because a week time has passed. So the evidence isn't that strong for antipsychotics. Next is benzodiazepines, which can make delirium worse, especially if the patient has non-alcohol withdrawal delirium. That's the only appropriate instance to use benzos on a patient with delirium. Melatonin and Ramelteon, which are sleep aids, melatonin agonists, might help decrease the prevalence of delirium. Okay, so that's what I wanted to highlight in this review, this shorter presentation with delirium. Now let's look at section 3, neurocognitive disorders. So here's the DSM-5 criteria. Remember, delirium develops over a short period of time. Neurocognitive disorders and the dementias typically develop over a longer period of time. Once you determine someone has a neurocognitive disorder, you aren't done, because then you have to specify what type. Is it a neurocognitive disorder due to Alzheimer's disease or due to vascular disease, and so on. Rating scales can be really helpful here. MMSC is a very common scale, and this picture here is of the MoCA, the Montreal Cognitive Assessment, also very popular. Now let's look at Alzheimer's disease. DSM-5 criteria can be seen here. So this is an insidious onset, and then you have to determine if the patient has probable or possible Alzheimer's disease. Probable if you have an at-risk gene, if you do a genetic test, and possible if you don't. Pathophysiology can be seen here. So protein aggregates are your big concern in Alzheimer's disease. So amyloid beta can develop into these plaques outside of neurons and get in the way of neurons functioning, and tau proteins can cause neurofibrillary tangles inside cells. So it's attacking your neurons from the inside and the outside. Additionally, Alzheimer's disease decreases acetylcholine activity and causes excessive glutamate release. And these two things are important because this is how some of our medications work. The treatment guideline review can be seen here. So you're going to want to do non-pharm things, acetylcholinesterase inhibitors, memantine, or sometimes a combination of those treatments. Next is vascular dementia. So this is whenever a dementia forms after someone has a cerebrovascular event, such as a stroke or something like that. So the way to prevent vascular dementia is essentially the same as preventing a stroke. So if someone has risk factors like AFib or diabetes, you're going to want to treat those early. Treatment guidelines, they don't really recommend medications for vascular dementias. The medications don't have great evidence to support that they help here. Here's a quick review of a trial that showed acetylcholinesterase inhibitors didn't really have a clinically significant benefit in vascular dementia, but did have increased side effects. Next is Lewy body dementia. So Lewy body dementia is a type of dementia that has very specific symptoms. So someone has symptoms that are similar to Parkinson's disease and visual hallucinations, along with dementia, then it's most likely Lewy body dementia. Here's some of the risk factors and the prevalence. And this is caused, just like how Alzheimer's disease is caused by protein aggregates, this is caused by a different protein, alpha-synuclein, which is also seen in Parkinson's disease, which explains the similarity in some of the symptoms. Treatment guidelines are seen here, so a few non-pharm options, acetylcholinesterase inhibitors, and then second line is memantine. Next is frontotemporal dementia. So this dementia is interesting because there's a relative sparing of learning and memory and motor function. So the patient retains a lot of that abilities, but you will see either a behavioral variant or a language variant where they have different difficulties or differences in their behavior or in their language. The guidelines here are conflicting. One guideline says don't use meds, the other guideline says do use meds. So the evidence here is conflicting. And then there's many other types of neurocognitive disorders, but that we won't go into detail in this presentation. Next, let's briefly look at the medications. So there's three major types. We have acetylcholinesterase inhibitors, NMDA antagonists, and amyloid beta-directed antibodies. Acetylcholinesterase inhibitors are seen here: donepezil, galantamine, rivastigmine. So the mechanism here is that there's decreased acetylcholine in someone with a dementia. So acetylcholinesterase is the enzyme that breaks down acetylcholine. If you block that enzyme, you increase acetylcholine. So that's how these medications work. They increase acetylcholine, which can help with brain functioning. Here's the differences between the options. There's slight differences in mechanism, but formulation's another difference. So donepezil is just available as oral, galantamine is oral in solution, rivastigmine oral solution in patch. So that can be helpful. Side effects can be seen here. GI bleeds is a severe side effect that can happen, and NSAIDs can worsen that risk. So the adverse effects are listed below. Now let's look at the singular NMDA antagonist, which is memantine. So excessive NMDA can cause excitotoxicity, so kill neurons because there's too much excitement. and this prevents that from happening. Adverse effects can be seen here. It's relatively well-tolerated medication. Final medication is an amyloid beta-directed antibody. So this is aducanumab, brand name Aduhelm. So as you can tell from the name, it ends in mab. So this is a monoclonal antibody. And this specifically targets the beta amyloid plaques in Alzheimer's disease. So it's able to degrade those plaques. I have a lot more to say about this medication on my full presentation. Before you use this, you want to confirm that they have those beta amyloid plaques. So you do an MRI scan or a PET scan, or both in some instances. And then this is an IV infusion given every 4 weeks. There's a serious side effect here called ARIA, amyloid-related imaging abnormalities that can cause edema or microhemorrhages. Some other medications that can contribute, that can cause neurocognitive disorders, are anticholinergic medications and benzodiazepines. Finally, I wanted to go into the behavioral and psychological symptoms of dementia. There's no specific criteria for this, but many patients that have neurocognitive disorders have aggression or changes in behavior that can be difficult to manage. You want to do non-pharm options, so give the patient something to do. Have them listen to music, have them help and fold towels, redirect them, remove things like coats and hats that make them think they're going to leave soon, so make the environment as best you can. Pharmacologic options are sometimes used, antidepressants, antipsychotics, mood stabilizers, and so on. One of the big risks with antipsychotics is there's something called a black box warning, increased mortality in patients with dementia-related psychosis. So you really only want to use antipsychotics if the person's really aggressive or sexually inappropriate or harassing staff or things like that, not for minor reasons. Antidepressants can be used, mood stabilizers have little evidence, and acetylcholinesterase inhibitors are often used because the patient has dementia, but have little evidence specifically for the behavioral symptoms. If the patient does have inappropriate sexual behavior, again, you want to start with non-pharmacologic options, but medications are often used, with antidepressants commonly being used first line, but antipsychotics, anticonvulsants, and sometimes hormonal agents being used. So I hope that this was helpful in going through the background, then the neurocognitive disorders, with the major classifications being delirium, then the neurocognitive disorders that previously were referred to as dementias, and then finally the behavioral and psychological symptoms of dementia. So thank you so much for watching, and if you're curious to hear a more in-depth presentation, I did a full recording of my slides. Thank you so much for watching.